I think you have to figure out what you want to do, like Kyle said, and then you have to figure out how that fits in with the broader practice that you're a part of. And it's really important to build those relationships with your referring docs and keep those relationships up, right? If they send you a patient and you take out their bladder, just let them know how it went. Those folks in the community really appreciate that feedback of kind of staying involved and staying in the loop on what happened with the patient that they sent to you. You can't overstate the importance of just networking and keeping those relationships good and healthy.
Hello and welcome to our Winnovations podcast. I'm your host, Dr. Kyle A. Richards, and we have a super exciting program planned today. Season 2 of our program has been a lot of fun and filled with great knowledge and conversation, so we're thrilled to be back in the studio in the Department of Urology at the University of Wisconsin. Our podcast largely focuses on innovation within urology, but for this episode, we're going to hone in on the future of urology, the next generation of urologists. Transitioning from student to resident to practicing urologist has unique challenges, and we're here today to discuss those challenges. I'm pleased to be joined by Dr. Scott Johnson, Dr. Emily Polley, and Dr. Emily Davidson. Now I'm going to introduce each of our wonderful podcast guests. So Dr. Johnson, first off, Scott's a practicing young urologist at the Medical College of Wisconsin. You like how I refer to you as a young urologist, Scott?
Yeah, I do like that. You can continue. That's great.
Well, he specializes in urologic oncology, and I actually met Scott. He did his fellowship at the University of Chicago just after I had departed there, and that's when we had crossed paths. I mean, he's been on faculty for...
who's young now, Kyle?
Yeah, you're a few years younger than me, so I'm a little jealous. But and he's been on faculty for 8 years. Has it been 8 years, Scott? Or am I off there? 8 years.
Yeah, it has. It's been 8 years. It doesn't seem like it all the time, but it has.
And he went back to MCW after finishing his fellowship at the University of Chicago. He also went on to receive his master's in business administration and is the current chief of urologic oncology in the Department of Urology at MCW. Welcome to the program, Scott.
Thank you. Glad to be here.
Now, moving on to our next guest, Dr. Emily Polley is a fourth-year resident at the Medical College of Wisconsin. She enjoys playing with her dog as well as cross-stitch and baking, and she is planning on doing a GU reconstructive fellowship when she completes her residency. She's originally from South Carolina and did her medical school at the University of South Carolina. Welcome to the program, Emily.
Thank you. Looking forward to it.
And Dr. Emily Davidson. She is a fourth-year resident here at the University of Wisconsin. She enjoys food and cats, reminding me of sort of Garfield, I guess, to some extent, which we all love Garfield. And she's planning on going into practice upon completion of her residency. She's originally from Brookfield, Wisconsin, and did her undergrad and med school at UW, so-called UW Lifer. So welcome to the program, Emily.
Yeah, a triple badger is what we like to call it. So
we are absolutely thrilled to have all of you together today in our studio, where the host actually becomes the guest and the guest becomes host, as the two Emilys will be asking myself and Dr. Johnson their burning questions for our session, which we're calling, I'm done with residency. Now what? All right, I'm going to turn it to the Emilys. You guys are going to ask us your burning questions about some of the challenges of transitioning from trainee to attending.
Yeah, sounds good. So, as fourth-year residents, we're coming up at the end of our residency. We're starting to think about jobs and what we're going to do next. So after you completed residency, what factors did you consider when you chose your first job? What were you looking for, and kind of what were the things that were most important to you?
Scott, you want to take the first stab at this one?
Well, I'll start by saying, one, I think you two and anyone listening to this podcast is probably doing the first important thing, which is ask questions, get insight from other people. Some of the things that I thought about, where do you want to live, is a big one. Where in the country? If your priority is a urban environment, that's going to kind of tailor what you need to look for in some of the other aspects. Whereas if you really want to be out in a rural area, that's also going to impact kind of some of the other parts of the job that you're going to be looking for. So that's a really big part. Hopefully by the time you've graduated, you've sorted out kind of what you want to do, whether it's fellowship or, if you're going to go into private practice, but location, what you want your practice to look like, how big of a practice do you want to join? And, there's obviously bigger groups to single solo practices, and what are you comfortable with? So those are some of the first things, where you're going to be, what type of practice, really without thinking about specific specialties. Kyle, do you have any other big things that you looked into or thought about?
I agree with everything Scott said. And I do think, for me at least, geography played a huge role. I'm a Scotty, born in the Milwaukee area, and after having gone away for my training, my wife and I were really quite eager to come back to Wisconsin. So for us, it was really a matter of, where do we want to live, proximity to family, and then it was seeing what jobs were available. Because if geography is something that was really important to us, then it was a matter of sort of figuring out what jobs are available in that region. And sometimes that means you have to just pick up the phone and call people. Sometimes it means, sending emails with your CV. There's definitely, a lot of job opportunities right now for urologists, because urologists are in pretty high demand. So I do think that there are opportunities all over the country. And then, big sort of dichotomy is, do you want to do academics or private practice? And some of that sort of obviously depends on your skill sets and what the need is. I think it's maybe a little bit harder to crack academics, because there's not jobs that are necessarily available at the academic medical center, and they won't necessarily just create a job for you if they don't have the space. So those are just some considerations as you guys start looking. I guess I was going to flip the question to Emily Polley. Are you thinking academics or private practice once you're done with your fellowship?
I think I'd like to do academics. I really do enjoy teaching medical students and residents below me. I understand, it all depends on the job market at the time you graduate, and that may be something that I explore a little bit later in my career. But as I'm starting out, I'm mostly concerned with location, being close to family back in the Southeast. But we'll see where life takes me, 10 or 20 years from now. But I'm trying to keep an open mind regardless.
Yeah. One step at a time. Yeah.
I don't think it limits you necessarily, but it does make the pieces a little bit more tricky to put together, right? If you want to be in a certain area and you're committed to being academics, like Kyle said, the specific places that you can do those things in your region are probably more limited. And it depends on where you are in the country. There's certainly more limitations in different parts of the country than others. What about you, Emily? Emily Davidson. Sorry, I gotta specify which Emily we're talking about.
Yeah. So I would love to stay in Wisconsin, and I'm thinking that I would probably go into private practice or hospital-based practice over academics. As much as I love teaching and, that aspect of things, I'm also excited to kind of like be busy and kind of be on my own for a little bit. So, yeah, but I feel like we also, especially at UW, we've had attendings who have been in private practice and then ended up in academics. So, anything is possible if you're interested in that.
Yeah, I think
so.
It's super important to just be honest to yourself on what you want to do and what drives you. And if you're in a residency somewhere, I think all of us attendees want to hear that you're all going into academics, because that's what we did. And so that's kind of the default answer to say, but we need people that do private practice urology, and there's nothing wrong with that at all. I mean, I think whatever drives you to do, whether it's academics or private practice, you just have to be honest with yourself and what you enjoy doing. And if it's teaching, great. If it's you just want to be busy, and then that's great too.
Yeah, and if I have someone who needs a neobladder, I can always send them to Dr. Richards.
Yep. Yeah, or Dr. Johnson if you're closer to Freighter's when you set up shop. But that's so true. I mean, I really enjoy working with private practice groups in the region. I mean, it's a good collaborative relationship. And so even if you're in private practice, you can still be sort of connected to the academic center. So to me, that's really rewarding, is having those relationships with our community and regional urology providers.
Yeah, absolutely. And honestly, there's a lot of private practice urologists that do big time urologic surgery, right? You don't have to think as academics as doing the biggest surgeries or being involved with the most complex patients. I think it's more just a matter of where do you want to practice? Do you want to be involved with research, with teaching? You can really tailor your clinical practice however you want in a private or an academic setting.
Yeah, that totally makes sense. Kind of pivoting the conversation, but going off of this as well. When you're a new attending that's starting out, so you picked your job, you're in the academic center or private practice that you'd like to be in. What are some of the strategies that you found effective to building your practice when you're starting out?
It's, I think, less common where your first job, you're basically just taking over somebody else's practice that retired. Like that used to be more commonplace. Nowadays, it's more likely that you'll be tasked with building your own practice. I think it's important to sort of understand what kind of practice you want. Do you want to do robotics? Do you want to do recon? Do you want to do female urology, right? Because that's all kind of mixed in. Do you just want to do stones and BPH? Because then once you know sort of what you're passionate about, it may be you're passionate about a little bit of everything, which is okay. But if there's a certain area that you're like, you know what, I really want to build a HOLEP program because that's just what I love, then you're going to have to build that. They may not just be waiting for you. So you need to sort of go out there and advertise yourself. You can market yourself. You can try to get more referrals for patients with BPH. A lot of those patients come from primary care. So I think forging relationships with your referral base, which in many cases may be primary care, you could do a presentation to primary care and say, hey, I'm the new urologist in town. I'm really interested in this patient population, and they can specifically potentially start referring patients directly to you. Well, let's say you want to do prostate cancer. Well, you're going to have to see patients with elevated PSA then probably to make those diagnoses. So you can go to primary care and say, hey, I'm the new urologist in town. I'm really interested in prostate cancer and early detection. Let me come give you a talk on early detection of prostate cancer. And then before you know it, you're going to have a lot of patients showing up to your clinic with elevated PSA. And you'll find a fair amount of prostate cancer that way. So I think those are sort of some strategies. In academics, I've tried to meet all the urologists in the region and say, hey, I'm really interested in bladder cancer. I don't know. What do you think, Scott? How would you approach it?
Yeah, I think those are all excellent points. I think the tendency when you're starting out is to kind of stress about this, probably more than you need to, though. I remember when I started, I was relatively busy when I first started, but I didn't think I was busy enough. And I had people telling me, just enjoy the time that you don't fill all your block. It's okay. You don't fill your whole clinic. It's okay. Just, it's going to come and it's going to fill up and it's never going to not fill after that, so enjoy the time. Like you're going to get busy. And I've seen people that have come after me that it's the same thing. There's this kind of anxiety about pulling your weight and building your practice quickly. But if I could go back and tell my former self, I'd say, listen to all the people that told you not to worry about it because you're going to get busy. I think you have to figure out what you want to do, like Kyle said, and then you have to figure out how that fits in with the broader practice that you're a part of. And it's really important to build those relationships with your referring docs and keep those relationships up, right? If they send you a patient and you take out their bladder, just let them know how it went. Those folks in the community really appreciate that feedback of kind of staying involved and staying in the loop on what happened with the patient that they sent to you. You can't overstate the importance of just networking and keeping those relationships good and healthy. So,
and that part too is really, for me, that's really actually gives me energy. It's really fulfilling to have those conversations with referring docs. And so to me, it helps actually to combat burnout because it's almost like I make all these new connections and these new friends, whether they be primary care or other urologists in the region, and it helps to kind of lift me up. And it's good for the patients too, because then you can sort of share patients, especially if they're coming from a long distance. It's really a I think, a good strategy to reduce burnouts as well.
I think you're absolutely right, Kyle. In our field especially, I think there's this tendency to kind of feel like it's all on you and you have to take care of everybody and all the post-op visits and care and stuff. But I think if you involve the referring docs and the whole team that maybe aren't just in your center, it can undo some of that burden and really make you feel like a part of a broader team.
Thanks for answering those questions. I guess kind of jumping off of that, what would you say surprised each of you the most your first year as an attending? Expectations versus reality.
Ooh, I'm thinking about that one. I don't know. I guess for me, I was a little bit surprised with how nervous I was because it's so different. You always had, like, even as a resident or then as a fellow, there was always somebody there to sort of back you up. And now the buck stops with you. You don't really know how that feels until you're done, and then it's just you and the patient and then the beep of the anesthesia machine. I mean, I knew it was coming, but I just didn't know how I would feel about it. So the angst of that, especially for, some big cases, was real. And you just have to trust your training and trust the process. That first year, I just kept thinking, what would Schallhoff be doing right now, or what would Steinberg be doing? And then I would just try to do the same thing, just maybe yell a little bit less.
I agree completely. I vividly remember, Kyle and I both trained with Gary Steinberg, who was an excellent bladder cancer surgeon. And we both learned a lot from him. But I remember at the end of fellowship, he sat me down and it was kind of like, yeah, you think you know all this, you can do a cystectomy skin to skin, but when it's just you, it's going to be a lot different. And he was right. And I don't know if I really believed it at the time. You think, like Kyle said, you can do whatever case, you've done it before in residency or fellowship, and it's a lot easier to feel confident about it when there's somebody backing you up, no matter how near or far away that they are. There's somebody to back you up, and it's a different feeling when you're the only one. But it gets to another point, which you may be asking us about later, which is surround yourself with people that can help you, right? And when I first started some of the bigger cases that I did, I made sure that I had people that I trusted and people that I wouldn't be shy about calling into the room if I had trouble. I made sure that they were nearby. And there were a few times that I did need them, but even if I didn't need them, it was comforting just to know that somebody was on campus should I need help with this or that. I don't know if you did that, Kyle, but I thought that it was a good strategy. It helped relieve some of the anxiety early on that came with some of these bigger cases.
I certainly did. Until I felt like I was starting to hit my stride, I would always sort of know where my partners were and made sure that somebody was around. And I would give them a heads up and say, hey, I've got this complex case. Can you pop in if I need you tomorrow? And they were gracious enough to do so. And whether I needed them or not, as Scott said, at least I felt better knowing that if I got into trouble, there was somebody there to help back me up. We call it the load the boat phenomenon in surgery. Even now, if I have a complex case, Emily Davidson knows this working with me a lot. I get vascular surgeon involved. I'm not afraid to have colorectal if I know there are going to be some sticky bowel situations. So when you start your jobs, it's good to befriend some of these other services. And obviously, if they help you, you'll help them. It goes both ways.
Yeah. So our next question kind of alludes to that as well. When you're the new attending, how do you prevent yourself from feeling isolated? You said talk to other services, that type of thing. But even when it's not you in the OR, say you're in clinic and you've got something complex going on, or you just had a long day at work, how do you prevent yourself from feeling isolated when you first start out?
I think you have your groups of people that you lean on, whether that's colleagues in your new practice, whether it's co-fellows, co-residents. I mean, I have a number of different text chains that, we bounce things off of, right? And so, keep those relationships that you've made in residency and fellowship or throughout all of your training, and bounce things off each other. Like Kyle and I are both in oncology, and we have the luxury of having tumor boards where we can talk across disciplines about certain patients. That's a good way of kind of forging relationships and talking about patients in kind of more of a formal way. But even informally, you're the people that trained you, the people that you trained with, don't be afraid to bounce things off of those people.
Thanks for answering that. What are some ways, or how do you cope with that feeling of overwhelm that you described when you were first starting out?
I think starting your first job or even moving from one job to another, it can be really hard because you're sort of the new kid on the block and you're a little bit under the microscope. Maybe not a little bit, but you are under the microscope, and people are going to be watching like everything you do. It's hard because you feel that sort of pressure. So the best way to combat that is to take really, really good care of your patients. Because if you provide outstanding, exceptional care, and we're all going to have complications, right? The only people that don't have complications are those that don't operate. So if you're operating, you're going to have complications. So if you're having a complication, how do you react to it? How do you manage it? People are going to look at that. And they'll also look at how you interact with the ancillary staff, the nurses, the MAs, the techs in the operating room. You don't want to get labeled as the jerk of the department, right? And that can happen pretty early if you're not careful. Sometimes when you're under that stress, you might act in certain ways that aren't characteristic of who you are. So just be very careful when you first start, do everything by the book. Don't take too much risk on. And I think that help you to sort of manage getting to know the people in your group. The sort of sense of being overwhelmed, I say just don't take on too much. If you're going to do a major case early on, just do one. Don't do two in a day. I was able to push it out as long as I could because I did not want to do two major cases in a day and feel just that sense of dread and overwhelming. If I would do one major case, then maybe I would, do like a couple of small cases to follow. And always try to start with your major case when you're at the beginning of the day. You're the freshest. So I would recommend doing those things.
And don't do the hardest cases, right? Your first case doesn't have to be a level 4 thrombus. Like Kyle said, people are watching you. You're under the microscope. People are forming impressions of you. Your OR staff, they're all forming impressions, whether they're formal kind of evaluations or not. You want your initial impressions to be good. So not that you have to absolutely pick the easiest cases, but if there's a really challenging case that you see in clinic, do it with one of your partners, or maybe pass it off to one of your partners. There's no shame in that. Start off on a good foot.
That's a good answer. I like that. Something that I feel like I didn't necessarily think about, but someone saying it, I'm like, oh yeah, that does make sense. So in terms of like choosing what cases and taking good care of your patients, what tools or strategies did you guys use to track your outcomes when you first became an attending?
Early on, I would urge you to see your own post-ops. I know there are some people that tend to, I've seen this happen where they'll do an operation and they might see them back once and then maybe they'll release them to the APP or send them somewhere else. But I think the only way you know your outcomes is by seeing your post-operative patients. In fact, I get a lot of fulfillment out of that, building those relationships with patients and seeing them, month or year after year. So I think seeing your patients back, that gives you the best feedback that you can have, right? If you're doing an operation where functional outcomes are important, you can ask that patient, how many pads a day are you going through? How are your erections? And then keep track of that. I had a notebook where I would write everything down in, especially for functional outcomes, if you're concerned about that, or if you're doing cancer surgery and you're concerned about like positive margin rates and stuff like that. No one's going to track those outcomes for you, as I think you're pointing out. And it's important to know where you're at, because if you're not achieving the outcomes that you had hoped, then you can make adjustments, right? The only way you'll know what your outcomes are is if you keep an eye on it. So just seeing your patients back and follow up. And then for me, it was as simple as I'd have a notebook and I would just write down, okay, this patient's 3 months post-prostatectomy and they're at, 2 or 3 pads a day. Oh, now they're back at 6 months. They're down to 1 pad a day. Okay, we're making progress. This is good. I don't know. That's sort of how I've done it. What about you, Scott?
Yeah, I think some great advice that I got before I started my job was just to write down or somewhere kind of your thoughts about how the case went. Not really necessarily to record and keep track of kind of how things went, but more, I think it's more valuable just from a reflection standpoint to take a few minutes and kind of say, like, debrief a little bit after the case and say, all right, what went good with that? What didn't go so well? If you're doing something robotically and the ports weren't quite right, what would you have done differently? So that's not really so much answering your question as to how do you track outcomes, but I think it's important to just think about the case, reflect on what went good, and take a little time to do that. So hopefully next time you can learn on each successive case. You'd be surprised how fast, once you get busy, how fast you forget what happened. You will do a case and it will be, I don't know how you are, Kyle. You do a big case and you're mentally in that case and you go home, and the next day, if you didn't kind of think about it and write down exactly what happened, it's a lot of that could be gone. I mean, if there was a big event, maybe you remember it, but some of the details, some of the little nuanced things, like where a port would have been better placed or something like that, if you don't kind of record that in the moment, at least my mind is on to other things. I can't remember that stuff.
And one thing that I'll do is I'll actually put it in my op notes up at the top under the sort of intraoperative findings. I have an intraop findings section. So if I have like a really tough bladder neck dissection or a huge median lobe, or I'll document it there. I just know that, if I'm seeing the patient in follow-up and they're maybe not doing as well as I thought they would, or things aren't progressing as normal, I can just quick go to my op note, look at the findings section, and if it's my standard template and I didn't document anything, then I know the case was smooth, or I forgot to document, one of the two things. But I try to put it in there just as a way of just calling it out. You could bury it like in the paragraph, but if I put it, in the findings section that this was like a really tough anastomosis or something of that nature, I think it's good to put it in there.
Yeah, so that you can recall it quickly. If you're in a busy clinic, you want to see, hey, what might have gone differently about this case? That's good advice.
Kind of piggybacking off of that, how do you keep track of pathology and results for patients, like getting started managing the dreaded inbox, and kind of a corollary to that, like figuring out your clinic workflow with your support staff and how the inbox is going to be managed? Is that something that you bring up in an interview, or is that something that you just kind of had to figure out on the fly when you started your job?
Well, I was actually going to ask Kyle to tell me how to manage my inbox because I could use some pointers. So I'm hoping that he has some great advice here.
Well, it's a great question, Emily, and there's no perfect answer for inbox management. I do think that the onus is on us as the providers to follow up on results and pathology. And when I first started at UW, a lot of that was actually going to this sort of nurse triage pool. And I didn't like it, to be frank. So I actually told them that I want all results to come to me, which maybe was a mistake. Because I don't know, maybe I just like to be in control. It actually created more messages back and forth, whereas I could see the urine culture, I knew that it was asymptomatic bacteriuria, and I could just delete it. So that's sort of how my approach has been. So everything comes to my inbox, and I try to stay on top of it. And the real question is, what do you do when you go on vacation, right? Because you might get 100 inbox messages or results in a day, and then if you're gone for a week, now you've got 700 messages or pieces of data just waiting for you? I don't have the answer to that yet, Scott, but
Shoot.
but we could do a whole separate podcast on sort of, how do you manage your vacation?
Yeah.
Which I think is important because we have to do better in that regard. But for me, at least, what I can say is that it's best if I manage my own inbox, and it can be a challenge, but if you just stay on top of it and try to not get, in too much of a hole, I think it's really a reasonable thing to do. And that way you're able to know what's going on with your patients and you can provide the best, I think, possible care.
Yeah, I don't have a perfect system. There's kind of flaws to every little way that I've tried to manage it, but it's really important to try to stay on top of it, because once you start getting in a hole with your inbox or just managing any of this stuff, it becomes really difficult to get out of. But we have a great team of people, thank goodness, that helps me out. We have some APPs that help out with getting pathology results back and kind of making sure that the most important things are tended to when they need to be. And so I think that's part of my strategy is I do rely on other people a little bit, maybe more than what Kyle's saying, to make sure that I stay on top of it. But it's going to be different, whatever system you end up in terms of the team that you have to help you manage it. But it's something that you have to figure out. We all have to figure it out. There's no magic solution for this that's coming anytime soon. So, and it's something that honestly, we don't do, at least at MCW, I don't think we do a great job of teaching strategies on how to manage the inbox, in part because, like you're hearing from Kyle and I, we don't have any great answers, but it's something we all have to figure out, and it's not unique to us as urologists either.
And I do delegate certain tasks, I would say, but if it's something that I think would be better coming from me,
sure,
like, you've got cancer. To me, I'd want to hear that from my doctor, not a nurse. And that's just my opinion. But if it's, hey, you don't have cancer, I think that's fine, right? Then I can have a nurse or somebody else call a patient and say, yeah. Or in this sense, my chart has become really useful, because if I have negative test results, I can just send it to the patient via my chart with a dot phrase and then get rid of it. So nobody has to call the patient. So, learning how to work your EHR so that it works for you is a good skill to have. I'm a big fan of sort of dot phrases, and I was just at a meeting where someone was talking about generative AI within the EHR to sort of get AI to work for you. I'm kind of excited about some of that new stuff that's coming down the pike, so that you can take advantage of technology to make our lives a little bit easier.
I think if there's one good piece of advice, is put in the time up front to kind of figure out some of these things, whether it's dot phrases that you use to respond to messages. There are ways that the EMR can make your life somewhat easier, and so it's worth putting in the time to build your templates to kind of make things as efficient as possible. But it does take some upfront time and effort.
I'm a big fan of sending patients letters at the VA instead of the MyChart messages. But when you first start out, you have all of these patients in clinic. How do you figure out that workflow, or what was going to work for you, and how many patients you wanted to see per day? Is that something that just kind of came with time, or like you said, it was something that you kind of tried to figure out beforehand and adjusted as you went? How did that go for you?
I think for many of us, it's dictated kind of how many patients you're going to see. You might have some control over how you organize your clinic template, whether you have a clinic that's all new patients one day of the week, or whether you want new patients mixed in, or if you're doing procedures at the time of clinic, you might be able to organize kind of how you want those procedures. But in some way, you'll probably be told effectively like how many patients or there will be expectations, rather, is probably a better way of saying it. Don't you think, Kyle?
Yeah, I do. I mean, there generally will be some expectation, of how many new patients to see, how many follow-ups, procedures. Are you doing vasectomies and things like that, where you have to sort of block off a little bit more time? But I would say this, I wouldn't be eager to add on extra patients when you're first getting going. I would try to just kind of ease into it, like we talked about earlier, kind of do the bare minimum just to sort of get your feet underneath you. Health systems right now, there's more push to see more patients in fewer amount of time, and that creates a great source of frustration for many of us. And, so early on, I mean, I was able to kind of ease in. I could do my notes kind of in real time, right? So I would be able to walk out of clinic and all my notes would be signed and the charts would be closed. But as you get busier, you can't really, that's harder to do that. But that's something to aspire to, especially early on in your career, is getting those notes and those charts closed in real time so that you don't have to take them home with you that night, or you don't want the encounters to stay open longer. Don't overfill your schedule. If you can, just kind of do the bare minimum until you get your feet underneath you.
Yeah, as I mentioned earlier, you will get busy. And most of the time when you're starting off, you're going to be on some kind of guarantee. You're going to have time to build up your practice. And so people expect it to take some time to build up a practice. That's just kind of the name of the game. You're going to start out slow and eventually get busier. And once you're busy, you're not going to become unbusy, most likely. But if you can figure out a way to get clinic done close to the end of clinic, I think that's best for me. Just like Kyle said, I know people that go home and do hours of charting after clinic. I couldn't do that. When I'm done with clinic, I'm done with clinic. And it does take some, maybe a little bit prep work up front and some systems that you kind of have to organize on how you're going to do your notes and figuring out whatever your smart phrases and things like that, kind of efficient ways to manage Epic or whatever your EMR is. But one of my major goals of clinic is when I'm done with clinic, I'm done with clinic.
That's always my aspiration, but I tend to fall short in that area, Scott.
I don't know if either of you had this situation come up. I know we talked about it a little bit earlier, but not taking on the biggest cases when you're first starting out. How do you say no to things that you don't yet feel comfortable doing? Like, how do you find your voice in that regard? And then knowing, if you have to say no to a patient, how do you have that conversation? And then where do you send them, knowing where to send them?
Yeah, the art of saying no, it's not easy. And this could go not just to saying no to a patient, but to, let's say your boss asks you to do something that really you're not maybe the most excited about. Like, how do you say no to that? That's also an important question that you have to ask yourself. But if there's a patient that you see, maybe they want some sort of treatment and you don't think that it's the right thing for that patient, you should always do what you feel in your heart is the right thing. You should never be pushed into a corner to maybe do a procedure or treatment that you feel is just not the right thing to do. So it's not a good idea to sort of argue with a patient if it comes to that. And you can always refer them to another colleague and say, hey, I just don't think that I'm the right urologist to treat this problem, but I do have another person that I think you can see, and I'm just not the right person for this problem. And I think that's a good way of putting it to a patient. The other thing too, in the cancer world, you could have them see a medical oncologist or a radiation oncologist. Like if somebody is really adamant about having surgery, but you feel like radiation is a better option, getting another opinion is not a bad thing. And you could present it to the patient as such. We need you to get another opinion, because the more cohesive sort of plan we can put together, then the patient will hopefully buy into that. So, And maybe you have to communicate too. If you're going to get another opinion from a radiation oncologist or another urologist, it's probably good to give them a heads up. So I'll just leave it at that. And I don't know if Scott has anything else to add to that.
To be totally honest, when you're first starting out, you probably shouldn't say no to a lot of those things.
That's true.
And then you're building up your career, and hopefully your boss, your chair, whoever it is, has your interests and your goals at heart when they're offering you to do things. And so I didn't say no to a lot of those things to start out with. But from a patient side, what you're both getting at, I think that if you're not comfortable with anything, or the patient's not comfortable with something with you, never hesitate to have them see somebody else. Whether you're not comfortable doing what they're asking, or they kind of even hint at the idea that maybe they want to see somebody else about it. I think there's this tendency to try to talk them out of that sometimes, that no, you've got the best plans or best recommendations, but that is a wormhole you do not want to go down. So I encourage anyone that even remotely wants to talk to someone else or do something else, just encourage them to get another opinion. And sometimes just having somebody else talk through things with them and might have them see it another way. You might also be wrong. Who knows? So it's never a bad thing to have somebody else talk to a patient if there's any, even the slightest chance that they or you want them to do that.
I feel like this has all been really great advice. Thanks for answering our questions. Our final question is just if you have any other general advice for recent graduates from residency as they begin their careers, or any other pearls of advice that you'd like to share with us.
Oh, that's good. Scott, do you want to start?
I don't know that I have any great pearls. I would say we've all been through this. I think that's what I would say is we've been in your shoes, and you're, like I said earlier, that you're doing probably a better job than I did at this point, and just kind of raising these questions and talking to people. And if you're listening to this podcast, you're probably doing more than I did. And that's a good thing. I don't have all the answers, but there's certainly some things that I would have thought about a little bit more. Not that I have any regrets about anything at all, but it's just funny the things that you didn't think about that maybe you would have. And you have a lot of control, right? And you might get offered a job and kind of think, well, maybe I need to settle for this and this about this job because somebody just offered me a job, and that's great. And it is great. But especially like Kyle said, urologists are in high demand. And unless you verbalize kind of what you want and the practice that you want to be in, it's going to be real hard to build that. And you have a lot of control over those things. So ask those questions. Don't be afraid to tell people your ideal setup. You may or may not be able to get it. And be honest with yourself about what you want, what you want your practice to look like, what you want your work-life balance to be like. How busy do you want to be? Don't do it for somebody else. Really be honest with what you want to do and what motivates you. And I think you'll end up in a good spot.
I agree with all that, Scott. I think that was well said. I would just add, just enjoy the ride. Like what we do, don't lose sight of that. This is a huge privilege in my mind to do surgery, to take care of patients. Like don't ever lose sight of that as you're going through this, despite all the angst and the issues with transitioning from trainee to attending. It's a privilege what we do, and keep that in mind. Keep that in mind. So I think we'll end on that note. Thank you guys so much, Dr. Emily Davidson, Dr. Emily Polley, Dr. Scott Johnson. You guys have been phenomenal on this edition of I'm Done with Residency, Now What? Winnovations podcast. And I wish you guys all have a great rest of your day. I want to thank our editor and producer, Sandra Miller, as well as Dr. Steve Nakata, chairman of the Department of Urology at University of Wisconsin. And thank you to all our listeners for tuning in.
Winnovations is a production from the Department of Urology at the University of Wisconsin-Madison School of Medicine and Public Health. Thanks for listening.